All right, well, we'll go ahead and get started. Thank you all for being here. My name's Adam Layton. I'm an emergency physician and intensivist from the Johns Hopkins University School of Medicine and the vice chair of the IFEM Critical Care Special Interest Group, who is sponsoring and organizing the session. And so I'll just toss in a brief plug of self-promotion that anybody who's interested in the overlap of emergency medicine, critical care, and early critical care in resource-limited settings, please give me a shout. Our special interest group is a diverse, vibrant, robust group of emergency physicians and intensivists from around the world, and we would love to have more participation from all countries and all continents, including yourselves. So my email will be on this at the end. I'll also toss out just the interesting piece of trivia that really we're focusing on early critical care. And for those of you who say, early critical care, what's that? I'd advise you to check out the white paper by our SIG on early critical care in low resource settings that was published in the Annals of Global Health this past year. Our chair, Leah Lizonsky, is the first author in that. I'm very excited to have an illustrious panel of emergency physicians talking about early critical care in low resource settings, adapting resuscitation strategies to save lives, including Dr. Amelia Poussin from Hopkins, Dr. Bachar Hamade from the Cleveland Clinic, and Dr. David Tang from Northwell. I'm a little bit of a bum and waited until this morning to ask them to send me their bios, and they're equally a little bit of bums for not sending me more detailed bios on all of their numerous accomplishments and titles. So I'll let them each introduce themselves a little bit more, but I will move on and hand the podium to Dr. Hamade to get started.
Well, thank you, Adam. Thank you, everyone, for being here. So, like Adam mentioned, I'm both an emergency physician and an intensivist at the Cleveland Clinic. I graduated from Hopkins from emergency medicine and then followed that with a critical care fellowship at UPMC. And then I moved back to Lebanon, which is my kind of motherland, and worked there for a year in both specialties, and kind of was there during the Beirut blast as well, and then decided to relocate back to the US. So I practice 50-50 emergency medicine and critical care at the clinic, and as part of this panel today, we'll be discussing respiratory failure in limited resources setting and kind of how to adapt your strategies to save lives when you don't have all the tools in your pocket. So thank you for giving me the chance. All right, so the talk will be an outline of obviously kind of management of respiratory failure, and we'll kind of briefly talk about, high flow nasal cannula modifications and non-invasive positive pressure ventilation, intubation and mechanical ventilation, and all the challenges that come with this when you practice in a very low resource income setting. So imagine you're working in, I'm going to say Beirut because that's where I used to work, and it's COVID season, so it's obviously very bad because it's low resource. And the family brings in a patient who's, a 72-year-old male, and the vital signs are obviously super abnormal, as you can see, and the patient's smoker and hypertensive. And so you, as practicing there, coming from, the US, obviously asked to put the patient in an isolation room. However, there is no isolation room. And so that's, problem number one, where if you have an isolation room, it's probably filling up very quickly. And two, now you're kind of faced with where I'm going to put this patient. And so you actually probably have nowhere to place this patient, and sometimes you actually have to practice emergency medicine outside of the hospital, which we did on numerous settings, especially in the Beirut blast, for example. So this is a challenge because now you have to mobilize, your team to try to take some nurses out, maybe a respiratory therapist if you're lucky to have one, and maybe take out, a few oxygen tanks to help the patient out front. And so you might have to treat them in the parking lot. So that is kind of challenge number one in terms of space and allocation. However, let's say you are able to eventually, manage to figure out where to put, the patient back in the emergency department. And so you start, going down kind of your algorithm of how to, support this patient from an oxygenation perspective. So you put on a nasal cannula, and that doesn't really work. And so you put on a non-rebreather cannula. Non-rebreather face mask, and that also that doesn't really work. And the patient's still desaturating. So now you're like, well, I know kind of what to do. I need to get a high flow nasal cannula on because, this is type 1 respiratory failure and, that works. And then maybe I'll use a CPAP. However, the patient continues to desat, so you ask for the high flow nasal cannula. And you kind of don't have one, which is also a bummer. Because high flow nasal cannula actually really does work in type 1 respiratory failure. However, the problem is when you're in a low resource income setting is that it consumes a lot of oxygen, which you actually might not have. So some places you will go work at might not have wall supplies of oxygen, and so you're going to have to run through a lot of tanks. At 60 liters a minute, that's a lot of oxygen to go through. And this is kind of a quick kind of schematic representation of the tanks that you usually use maybe on a day-to-day basis in transporting patients in the hospital. So an E-tank has a capacity of 680 liters, and so at 60 liters a minute, you're going to need a tank every 11 minutes. And you might not have that, so that luxury is not there. Whereas an H-tank, can fit around 7,000 liters, and at 60 liters a minute, you're going to need a tank every 2 hours. So that also is a pretty bad situation to be in. This is kind of a quick overview of how much oxygen you need if you have 3 patients on nasal cannula at 5 liters a minute, 1 on a ventilator, 1 on high flow nasal cannula, and 1 on CPAP. And this is a pretty good resource called opencriticalcare.org, which has a nice kind of computerized input where you can plug in all of this stuff, and you're able to generate a number and see how much oxygen you need. So just kind of these patients alone that you randomly take for granted are being managed, kind of just with the flow of things during the day, are going to use per day 156,000 liters of oxygen. And so you can imagine that that is not a luxury that you might have in all of these places. So you got to take that into account. So what to do is you can sometimes kind of MacGyver and do it yourself a high flow nasal cannula, where this was described in an article by Kumar et al., where you can put a nasal cannula flush and throw a non-rebreather on top of it. And it can give you a little bit more of a higher flow, improves oxygen-air mixing, improves the oxygen concentration delivered to the patient, and might benefit them in type 1 respiratory failure. Granted, you have a wall supply or a tank to be able to give nasal cannula, but you're not giving high flows at 60 liters per minute. And it also helps decrease in rebreathing. So it's kind of something that you can actually come up with on the spot. And it doesn't take a lot of equipment. You're already using those. Just do them together. So back to the case, you do that, and your patient, the stats are also not improving. So now you think, well, all right, I'm a smart physician, probably got a little bit of a shunt issue. I might need some pressure. So I'm going to get a CPAP or a BiPAP. Well, also bummer, that also is not available. So what you can do in that setting is you can also MacGyver your own kind of CPAP and something called a wall CPAP. And that's when you don't have an actual machine or you don't have a ventilator available to be able to generate that positive pressure that you want. And it only requires, very simple tools that you most likely will have, which is either a tank or, wall oxygen, a Y connector, which you should have, hopefully, some tubing that you will need, and obviously just kind of some water and like a little reservoir tank. And this is what it kind of looks like. As you can see, this is a mannequin, obviously, but let's say your patient's over there. You basically need some tubing to allow oxygen to be delivered from the wall supply into that closed limb where the Y connector is, as you can see on the far right. Air goes in, patient breathes in air, and then there's an exhalation hose and a pop-off valve, and the exhalation limb is actually plugged into this water reservoir, and you tape the tube at 5 centimeters below the water level, generating a pressure of like 5. So during inhalation, positive pressure is created by the rapid inflow of air from the outlet. And during exhalation, the force required to exhale through the water will give you basically a PEEP. It's not obviously a BiPAP. It's basically just a CPAP, and it just generates a little bit of pressure that you might need to improve your oxygenation in such a patient. So that is another kind of trick that you can use when you don't have a ventilator available. So that also doesn't work, and now you come to basically, what we all like to do in the emergency department, kind of the high five procedure, was basically intubate the patient. It's all nice and dandy when you have all of the equipment that you need, but also the problem is in low resource income settings, it's not always, a great day when you intubate. And the reason is, intubations in places that are underserved are very high risk, and they're associated with around 72% mortality. So The moment you intubate somebody over there, they've got a 72% of not ever walking out of this hospital, compared to 30% in high-income settings. The lung-safe study actually showed that in places with a higher GDP and just kind of better socioeconomic demographics, there's a lower mortality in intubated patients, and actually just the mere increase of $1,000 in terms of salary is associated with an odds ratio of 0.9 in terms of mortality. And obviously in those places where you're practicing in low resource settings, the more you have patients intubated, the more ventilator-associated pneumonias, which is also associated with increased mortality and more complications down the line. So it's not always a great option to intubate a patient, and I'll talk about it a little bit and why it should be almost kind of really your last resort. So what to expect when you're intubating a patient or when you make the decision to intubate a patient in those settings is that you really don't have equipment. There's going to be a lot of lack of equipment. You're going to have inconsistent ventilators in the ER or in the ICU. And one study in India showed that 120 ICUs that were inadequately equipped actually were associated with a really higher mortality. So a lack of trained personnel and lack of equipment are like the single greatest barriers to improve care in those countries. We all saw here kind of in COVID how the system got so strained that we all kind of suffered from that perspective, but that's basically like a day-to-day kind of year-to-year thing over there. So you have to take that into account. A lot of equipment challenges that we talked about. You have to consider that you're going to a place where manuals might be in different languages, and also you're going to have inconsistent ventilators, because a lot of these places get ventilators as donations, which means that not every ventilator is going to be the same. So if you're used to working on one type of ventilator and one ICU here, you might have to kind of get used to working with like 5 different ones. If they stop working, you're probably not going to have somebody to kind of help you with repairing them, so you've probably lost a ventilator. You might have to reuse the same tubing, which means you're going to have cross-contamination. You have an unreliable oxygen supply that we talked about, inconsistent electricity, which obviously we take for granted here, but we've worked in like power outages a lot back home, and if you don't have a generator, then also that's kind of something that you have to account for. And then circuit humidification might be something very scarce, and the problem here is secretion buildup and obviously poor outcomes on a patient who's being mechanically ventilated. Other small ancillary equipment challenges, pulse ox, you might not have that, and untitled CO2 monitoring, arterial blood gas analysis, and lack of portable imaging, so you can't get an x-ray on everyone that you want. Be familiar with this curve. It'll help you if you don't have a pulse ox. And a word of advice, sometimes you might actually have to take the equipment with you. You might have to buy a few pulse oxes and take them with you, or like an Untitled CO2 adapter. On opencriticalcare.org is another kind of nice little kind of calculator that you can put your saturation, and it gives you like a PaO2 and a PF ratio if you have your FiO2. So that's a good resource. Be familiar with direct laryngoscopy. We all moved to video, but if there's no power, then the glidoscope is useless. Be familiar with the available sedation. You might not have RTs, you might not have ABGs. Be consistent with the mode of ventilation that you use. Don't try to, learn different techniques when you're there. Just use one and be consistent with it. Have a checklist that you bring with you from over here in terms of managing those patients that are intubated, because they're going to board in the ER for a long time, and liberate the patients, as soon as possible from the ventilator, because that's the best thing that you can do to these patients if they don't need it. Boarding is a big problem because you don't have space, so that means a longer duration of mechanical ventilation, longer ICU and hospital length of stay, higher mortality, and it's exponentially worse in these settings. So take-home points, finally, is basically, expect the unexpected. You're going to have lack of equipment, bed space availability, oxygen is not always available. Do it yourself. Be familiar with nasal cannula, non-rebreather mimicking kind of high-flow nasal cannula. Be familiar with wall CPAP. Be familiar with online resources, hopefully if you have internet where you're going, or print them out, take them with you, be prepared, know your tools and resources. And remember that intubation is not always a solution. It sometimes is a bigger problem. And then you've kind of you opened up a whole can of worms on yourself. And that it's associated with a higher risk of mortality, so you might want to avoid it. Putting a tube between the cords is not always a solution. And that's all I have. Thank you.